the University of Michigan, I know that, is that we had a weekly vascular conference to talk about all the nuance of these patients. And so now I've started that here. We had our first vascular conference here, and I think it's a good idea because there's so much nuance to these patients, and I don't want to steal Mariana's thunder, so I'll stop talking and let her take it away. So Mariana, go ahead. Thanks for talking. Looks like Anish, our fellow's on the call too. So, all right. Thanks a
Yeah.
lot.
Can somebody confirm that my screen is sharing correctly? You
Yeah.
can see like the slides, not the like
Yep.
PowerPoint
Yes,
view.
we can see a slide, it's on presenter view, we can see it.
Yeah.
Okay,
And
perfect.
Amina, it's Amina and you and Eggy, right? In the crowd
Yes,
there. Okay.
yeah.
So great. Excellent. Hey, Eggy, how you doing?
Good in you guys.
Good, good. Excellent. So Eggy, what year are you again? What the third year resident? Fourth year?
I'm in my third year.
Third year. That's right. Okay. Great. Excellent. All right. Thanks a lot, Mariana. Go ahead.
Yeah, great. So as Dr. Becerra mentioned, I'm one of the second year residents here at Pitt. Feel free to jump in, ask questions, anything along the way. I'm gonna be talking about pulsatile tinnitus today. See if there we go. So just wanted to quickly start by going over like the two kind of broad categories of tinnitus. So there's subjective tinnitus, which is the perception of sound without any acoustic, electrical, or external stimulation. This is the most common type, typically associated with high frequency hearing loss. And this is where patients, we rely on their report of their experience to kind of characterize that tinnitus, whereas objective tinnitus is the perception of sound due to an internal body source or vibration, can be exacerbated by conductive hearing loss. And this we can have objective measures for, can hear kind of what they're experiencing as well. In terms of pulsatile tinnitus, two broad categories within that are vascular causes. So, in terms of arterial things, we can think about uncontrolled hypertension, carotid stenosis, aneurysms, all of those causing turbulent flow through a region. Also, high blood flow states like pregnancy, thyrotoxicosis, anemia, and then paragangliomas are another arterial cause. Or can be. And then venous causes can be idiopathic intracranial hypertension, Arnold-Chiari syndrome, dehiscent jugular bulb, sigmoid sinus stenosis. These are some things we commonly see in the clinic as well. And then non-vascular causes would be palate and middle ear myoclonus, superior canal dehiscence, things like that. So when we see a patient in the clinic who's coming in reporting pulsatile tinnitus, what are some things we might want to ask them from a history perspective? What do you want to know?
So in their history, you'd want to know if they've got any medical conditions such as high blood pressure or thyroid conditions. You want to make sure they're not pregnant. And then you could also go into finding out whether this tinnitus is pulsatile or non-pulsatile, and whether if it is pulsatile, whether it's synchronous or non-synchronous, and if they have any other associated hearing loss or any other any other symptoms associated with the disease.
Yeah.
You also want to know about drug history. Are they taking any medications? Have they had any history of trauma to the ear, any ear surgery? You want to know systemic diseases they might have, like we talked about thyroid disease, but hypertension and cardiac disease are important as well. Associated ear pain, ear discharge, as you try to narrow down the cause of the tinnitus.
Yeah, those are all great. So things I had, just to kind of add to that a little bit, laterality. So are they having it in one side or both sides? Onset, how long have they been experiencing this for? Are there any provoking or palliating kind of factors that they've noticed? The quality of the tinnitus, which you guys were getting at with like, is it synchronous, things like that? How severe is it? Can they distract from it? Can they not? Is it timing wise? Is it constant? Is it episodic? How long do the episodes last for if it is? You guys got at all of the like associated symptoms, comorbidities, medications, all those things. So once we've got our good history on them, what are we looking for from a physical exam perspective? Like, what are things we want to make sure we hit?
You need otoscopy, cranial nerve exam, vitals.
So you do a full head and neck ENT exam, including cranial nerves. You'd assess the neck. You can also listen to the neck or auscultate the neck when you breathe. You can also apply pressure to the neck and ask with compression on the neck, does the tinnitus improve or not? Because that can also give you a clue as to whether there's sort of a vascular component. And then on otoscopy, you'd want to look specifically to see if there's any retrotympanic mass behind the eardrum, which could also give you clues towards a pulsatile tinnitus, as well as any cranial nerve, lower cranial nerve fallout, but those could give you clues as to if this is something, involving the jugular foramen and something like a paraganglioma.
Yeah, great.
And then you want to do their normal vitals, blood pressure, heart rate, tuning forks. Yeah, I don't know.
Yeah, exactly. You guys hit it all. So vital signs, so like heart rate. One thing you can do too is, in terms of like, is it synchronous? Like as you're checking their heart rate, having them like tap out their tinnitus, confirm that it's matching. Blood pressure to get at, is this like a hypertensive kind of problem or being exacerbated by that? For otoscopy, pneumatic otoscopy can also be helpful to see if there are any findings from that standpoint. You guys got the cranial nerve exams, tuning fork testing, auscultation for carotid bruits, and then compression of vascular structure. So you hit all of those key points. So once we have our history and our physical, our evaluation and workup is next. What are some things that you think about ordering for these patients kind of right off the bat?
So you first and foremost need a pure tone audiogram to assess hearing. I mean, a lot of patients can have normal hearing with tinnitus. And then your clinical exam may also guide you to your further investigations. But essentially, if there's like, if you're worried about something in the carotid venous system, you could order duplex, what do you call it, duplex ultrasound of the neck to just assess the vasculature. If you see a retrotympanic mass behind the eardrum, you'd want to perhaps order high contrast CT temple bones. But then I think MRI or MRA is gold standard for picking up a lesion if you suspect something with pulsatile tinnitus. And then the other thing on clinical exam is, you'd want to look in the oral cavity to check for palatal myoclonus, because that can also be a cause of tinnitus. We did say audio, and then I suppose if you suspect idiopathic intracranial hypertension, it would be specifically in a patient, like I think they specifically describe it's a young female who has an increased BMI, with also associated visual loss, visual changes, then you would suspect idiopathic intracranial hypertension, and workup would go towards looking at further symptoms of that.
Yeah, absolutely. So I think, at least in our clinic and practice, and Dr. Passera or Anisha, Leah, let me know if I have any of this wrong or if you have other thoughts, but I think almost every patient gets an audiogram and TIMPs. Lab workup, a little bit mixed depending on what we think the etiology is in terms of like at least basic blood work, CBC, BMP, can kind of be guided based on what we think is going on. I would say almost all of our patients, we get a CT temporal bone or IAC and a CTA head and neck. And then MRV I was reading is, kind of the gold standard for if there's like concern for like a venous etiology, and then certainly would save a patient a lumbar puncture unless we have like a high suspicion for IH, and then, probably pending the earlier workup. And then an optic exam also for those patients to kind of look for papilledema. So absolutely right, kind of thinking about as we're going through our differential, which testing would be most appropriate. I will say that at least at UPMC, I think we are a pretty imaging forward institution. And so those things tend to be kind of part of our standard workup. Treatment is then really guided by our differential and then what the results of those tests are. So if everything comes back normal, there isn't like a clear cause for this. It's not that bothersome to the patient. There aren't any alarm features. Observation can be one option. Medical management for some etiologies like idiopathic intracranial hypertension. And then surgery if, there's like a canal dehiscence and a clear history that's really fitting for superior canal dehiscence syndrome. Resurfacing if there's dehiscence of like sigmoid sinus or Tegman defects, things like that. So I wanted to just go through some cases to kind of highlight how this workup thought process goes through. So our first case, we have MK. This is a 20-year-old female with right-sided pulsatile tinnitus described as a whooshing sound. So she comes in with this complaint. How do you want to proceed? What do you want to ask her?
So you want to ask her if she's got any medical comorbidities, if she has any thyroid disease that she's aware of, if she's pregnant, and then you'd go on to figure out whether her tinnitus is unilateral, but you say it's like right-sided, so it's unilateral pulsatile, whether it's synchronous or non-synchronous, you'd want to find out, and then you do a full clinical ear, nose, and throat exam, including the head and neck with cranial nerves, specifically assessing the neck to check if the pulsatile tinnitus improves with compression on the neck, and then specifically on otoscopy to look for a retrotympanic lesion or mass behind the eardrum. And if you're and then you do tuning forks to assess whether or not she's got a conductive or sensorineural hearing loss. And then I'd want to send her for a pure tone audiogram with tympanometry and your pressures and basic vitals.
Perfect. So she tells us that her tinnitus is most bothersome in quiet environments. She's a college student. She notices that in the classroom and when she's going to sleep at night. It increases in intensity if she moves her head quickly from side to side, decreases in severity if she presses behind the right ear. Associated symptoms, only occasional muffling of sounds in that ear. And then she denies otorrhea, otalgia, autophony, vertigo, imbalance, facial weakness, and hemispasm. No prior ear history or surgeries. So like you mentioned, we'll send her for an audiogram. This is what it comes back as. Can somebody walk me through what this audiogram shows?
Okay, so this is an audiogram. It's essentially actually, I think, showing, she's got any low frequency air conduction on the right. She's got perhaps some mild hearing loss, but otherwise it's normal, and she seems to have suprathreshold bone conduction.
Yeah, so I don't know if I would call this super normal bone conduction because she's at 0. My understanding, and please correct me, anybody on the call if I'm wrong, is that for it to be super normal, it would have to be below 0. But yes, essentially a normal audiogram. She does technically, as you pointed out, at 250 hertz have what would be like a mild hearing loss. I usually, in my notes, and again, somebody correct me if I shouldn't be doing this, call this like grossly normal audiogram, since this is, within 5 dB of normal and could just be testing variability. But she's got a good pure tone average. Word rec is 100%. So from an audiogram perspective, her hearing is great. So we sent her for a CT. I'm going to play through this. If you notice anything, just shout it out. Sorry, I probably started a little low on here.
Can you rewind a bit?
Absolutely. Sorry, let me adjust where my screen's.
Maybe about 30 seconds. 30 seconds. Okay.
About there.
Yep. Stop.
Mm-hmm. Yeah, exactly.
Okay. Can play.
Mm-hmm. Do you want me to keep playing?
Yeah, the sigmoid sinus on the right side seems very superficial. It could be the cut or rotation. Do we have coronals?
Unfortunately, I only saved the axials. That's a great point, though. Should have also pulled up the coronals for you. But yeah, so looking at her CT here, she has her right-sided, the sigmoid sinus has this diverticulum and is like thin to dehiscent over that. So possible cause for her tinnitus here. So she ended up going to the operating room. This is actually one of Dr. Basura's patients. At the time of surgery, she had normal mastoid anatomy. The sigmoid sinus was identified, which did show an outpouching and that diverticulum, which was cauterized to help kind of retract it, and then overlying repair with temporalis fascia, with some overlying bone cement to repair that dehiscence. And then obviously things we want to think about in cases where we're operating in the mastoid, middle ear, facial nerve, which was intact at the end of the case. And then that was closed. So she came back into clinic afterwards, noting marked improvement in her right-sided pulsatile tinnitus. She was at that point only hearing it in very quiet environments or with increased heart rate. So she was very happy with her surgery. All right.
I have
And,
a question.
yeah.
Sorry to put you on the spot, Greg. But so for the diverticulum, you did the canal wall up and decompress the sigmoid. Does the diverticulum look any different from what the sigmoid sinus looks like, or it's just a very prominent sinus?
It's more just like an outpouching there, Amana. So right at the central angle is like a little, it's almost like a little bleb or a little just diverticulum that was kind of pooched out there a little bit, so it created some turbulent flow. So the key on that is to not compromise the lumen of the sigmoid. You don't want to get overzealous and then wind up occluding the sigmoid sinus. So when I exposed it, you gently cauterized it and it kind of retracts down. Many times vessels with bipolar cautery, as you've probably seen, especially dural venous sinuses, will kind of retract. So that kind of naturally retracted it, and then I kind of relined that area with some fascia, and then I rebuilt some bone cement over it because it was partially dehiscent too, just to recover that. And that seemed to be just enough to kind of disrupt some of that turbulent flow. So yeah, so it looked, I mean, it was the same kind of consistency of a vessel, but it just had this like almost like be like the equivalent of an aneurysm on an artery. There's like a little outpouching, if you will. Yeah, I mean, she's had it her whole life. I mean, this is like she's 20. It was, basically there for a long time. I think it just became more increasingly symptomatic. So, yeah.
Yeah, great question. And thank you so much for jumping in there, Dr. Basura, to answer that. I wasn't in this patient's case. I saw her post-operatively, so that's super helpful to know.
And in fact, actually, we're seeing her back today.
Oh, yeah, that's right.
Yeah, she's on the schedule this morning just to check in and see how she's doing. Yeah.
Yeah. Any other questions about this case before we move on to the next one?
So if someone has like a dehiscent sigmoid sinus, so the bony covering over the sigmoid sinus is dehiscent, and they have pulsatile tinnitus, you could consider doing like a similar approach where you drill down and then cover that area of dehiscence with bone?
Yeah, that's correct. I think people do it in different ways, but yeah, you could do a similar repair with like a fascia and then overlying bone cement, or like a multi-layer like soft tissue coverage. I think everybody has slightly different philosophies, at least based on a couple of attendings that I've talked to about this, and how to approach the repair. But basically the idea is creating a new cover cap, to kind of replace that, to prevent that transmission of sound. Especially in folks who have very well aerated mastoids, you can imagine it creates space for that sound to transmit. So putting something over to kind of cover that sound and not let it echo within the mastoid chamber should reduce their symptoms.
Okay.
If I don't have bone cement, can I use bone pate? You think it would work? If I got some cortical bone dust and compressed it, would it do the same thing as cement if I don't have cement available to me?
Yeah, I think it could, Amana. Yeah, for sure. Sorry to interrupt you there, Mariana. Yeah, it definitely could. I would cover it with a little bit of fascia, and then you could put some bone pate around it while it's healing. You could try that for sure. Key is to not to compromise the lumen.
Great. Okay. Our next case is JD. This is a 57-year-old female presenting with bilateral tinnitus. So what are we going to ask her?
So you would want to know duration of the tinnitus. How was the onset? What does it sound like? If they can describe it using other terms, is it a buzzing sound? Is it high frequency? They can try to relate the tone to normal sounds. Is it pulsatile, in synchron with their heart rate, or is it random? Is it there all the time? What seems to make it worse? Is it louder in quiet places? How bothersome is it? Does it affect sleep? Is it affecting sometimes they get depressed or very socially deprived because of their anxiety? Would want to know about any addition of ear symptoms. Is there hearing loss? Is there pain? Do they have oral fullness? Do they have autophony? Any headaches? Ask about other cranial nerves, any facial asymmetry, facial pain. Ask about symptoms for the other cranial nerves as well, like do they have issues with their voice, issues swallowing, issues with their vision or dryness of the eyes. And then specifically for the ear, you would want to know, has she had any trauma to the head or both ears, any ear discharge in the past, any surgeries that they've had? If they do have a hearing loss, was it sudden onset? Was it progressive? Is it fluctuating loss? And then you'd want to know about systemic things, any comorbidities they have, specifically hypertension. Some patients with diabetes also get tinnitus. You want to know about thyroid disease, know about their menstrual health or any other medication that they are taking. Are they on any hormonal therapy? Are they taking any NSAIDs? Are they taking antihypertensives? Because all these can give tinnitus. You want to know about any other medications that received in the past. Have they had a cancer before? Have they had radiotherapy before? Any chemotherapy that could lead to this? What job does she do? We have noise exposure or ototoxic drug use that could trigger this from the history.
Great. That was incredibly thorough. So we've asked her all these questions. She tells us that it started several years ago. She hears her own voice in footfalls loudly. She has oral fullness, right worse than left, and then loud sounds in Valsalva trigger vertigo. So does anybody know the eponyms for that last piece? Like what is it called when loud sounds induce vertigo, and what is it called when Valsalva induces vertigo?
The Tunio phenomenon.
So loud sounds inducing vertigo is Tullio's phenomenon, and then Valsalva in vertigo is Henenberg's sign. Great. Great. So we got an audiogram on her. Can somebody walk me through this one?
So we have an audiogram showing us both the right and left ears with normal hearing bilaterally in the low and mid frequencies and downsloping to a mild sensory neural loss. But significantly is we have elevated bone thresholds, left more than right.
Yeah,
So
exactly.
it's giving almost a pseudo-conductive hearing loss, but when you look at the pure tone averages, you actually have normal hearing in the low and mid frequencies bilaterally, and then a drop in the high frequencies bilaterally.
Yeah, perfect. So she has this in the low frequency, she has an air bone gap, and these bone conduction thresholds are super normal. So they're above zero or below zero. So based on her history so far and this audiogram, what things are we thinking about?
So she most probably has a third window phenomenon, and given the positive Henneberg's and Tullio's phenomenon, we would think of a superior canal dehiscence as one of our differential diagnoses.
Yeah, perfect. So that would definitely be at the top of the differential. What is something else that can cause an air bone gap in lower frequencies, and what would be the test to kind of distinguish the two?
Another thing that can cause your question is a conductive loss in the low frequencies. Autosclerosis.
Exactly.
Autosclerosis would be a differential. And to differentiate the two, we'll do acoustic reflexes. Reflexes are absent in autosclerosis but present in canal dehiscence, superior semicircular canal dehiscence.
Yep, exactly. Perfect. I don't have stapedial reflexes on this patient, but that would be exactly it. So this patient is kind of a conglomerate of a couple different patients just to get the kind of characteristic findings. So I didn't have a full CT for this patient. It's actually somebody who I saw at Mass Eye and Ear when I was doing research there. But this is a image from the CT. This is the partial view. So kind of parallel or in line with that semicircular canal. We can see that there's a 47-degree region of dehiscence there. And then when this patient went for VEMP testing, this was the left side, which had that bigger air bone gap. What do we notice about the CVEMP thresholds on the left compared to the right?
They're lower. The thresholds are lower.
Exactly. And is that what we would expect with superior canal dehiscence? Like, does that increase our suspicion for this on the differential?
Yes, I think they have lower thresholds but higher amplitudes.
Yep, exactly. So just to quickly kind of go through VEMPs, I don't know if you find this as challenging as I do, but I always struggle a little bit to remember my VEMPs. So the CVEMPs are an acoustic stimulus. It's 95 dB click presented, and then the EMG response in the sternocleidomastoid is measured from the ipsilateral side, and that's a measure of the sacculocolic reflex. And so exactly like you said, in superior canal dehiscence, we have an increase in the sensitivity, decrease in the threshold. So higher amplitudes, lower threshold. And then ocular VEMPs, and then the CVEMPs all involve the saccule and the inferior vestibular nerve. Whereas the OVEMPs, you can use either air conduction, which elicits a response on the contralateral side, or bone conduction to elicit a bilateral response. And you're measuring the like EMD from the ocular kind of muscles. And that involves the utricle and the superior vestibular nerve. So brief kind of review of that. And then this video was actually from a repair that Dr. Basura did recently in clinic. So we'll watch through a couple clips here. So
just so you know, I didn't repair it in clinic. I repaired it in the OR.
Oh, sorry. I'm sorry. It's too early. I haven't done yet. Yeah, in clinic superior canal.
Just make sure that everybody knows that I'm not doing middle fossa surgery in the clinic.
Yeah, sorry, I misspoke there.
I mean, I'm
This
trying
was
to at some point,
repair.
but we'll get there.
Sorry, this repair was done at UPMC in our ORs. So as you can see, we have the malleable here, temporal lobe beneath that, and then sorry, let me restart this. And then this section here, we see, I don't know if you guys can see my pointer, but the suction and kind of pick here at the dome of the superior canal. And then this is tacile and bone pate, which was collected during the craniotomy, mixed into kind of like a gummy solution to gently pack the area. So we see it kind of getting into position there. And then let me get to our next clip here. And then we'll see that repair kind of placed. If it'll play. So just kind of gently guiding that little gummy to seal bone pate into the dome of the dehiscent superior canal, and then gently kind of packing it in. All right. Any questions about that case before we move on?
Just a small question. I always thought with superior canal dehiscence, we prefer the ocular vent because they're testing for the superior vestibular nerve. Is there a particular reason why we prefer the cervical vent for this patient? It's all it doesn't really matter if you do ocular or cervical.
I think I've more commonly seen cervical vents, but I'm actually not sure if that is based on like testing availability or ease, or if one is better than the other. I don't know if anybody more senior or experienced on the call has like insight into that. That's a good question.
I think a lot of it is experience and availability of the testing for the
Yeah.
most part. Yeah, some people aren't equipped to do both, but the cervical vent's a little more easy, a little more readily available.
Yeah.
Yeah.
Would they give you as reliable a response as the ocular vents, given that now you're testing the inferior vestibular nerve versus the superior? Would it matter?
I mean, again, it's an adjunctive. I mean, I've got to be convinced that on the CT, there's obvious dehiscence. And so most people will do a Stenver and a postural view on CT. And some will say you need to have 3 to 4 contiguous cuts on the scan that shows absent bone. Another physiologic principle people use, but not widely, is electrocochleography, or so ECOG ratios above 0.4 are also indicative of SPAP ratios above 0.4 are indicative of SSED. So my former institution, we used to do those pretty regularly. We used to do those intraoperatively. So you could actually follow the ECOG intraoperatively with plugging. So I, kind of use them again, like I said, I use the VEMP as an adjunctive. But for me, I think that I like to see radiographically convincing dehiscence. And then the decision tree is really if the symptoms they're having that are attributed to SSCD are disruptive enough to warrant surgery. I have a lot of patients where it's pretty clear they have dehiscence, but they're not symptomatic to the point where it warrants surgery. Yeah. Brad, what are your thoughts on testing versus your approach?
I have no opinion.
Yeah.
Steve Roush used to do a lot of the VEMP testing, and he always sort of emphasized that it was tricky, and and so I really haven't used it a lot, to be honest.
Yeah. So
And then you did a middle cranial fossa approach with this patient. as opposed to a transmastoid approach? What were the reasons you chose the middle cranial fossa?
I feel like I could get a better plugging from above, but you still certainly can do it from below. But a lot of it is the relationship of the middle fossa floor to the dome. So many times these folks have they can have a kind of a low flying tegmen. That can make it challenging to get to the canal. So in this situation, I think that was the case, but I think that for me, it's just ease of access. I feel like it's much easier for me to, because if you're plugging a canal from transmastoid, you're really fenestrating it on its lateral surface, and you're kind of plugging it from the side. If they've got some dehiscences, adjacent to that, you're trying to address that from a transmastoid side, which is fine, but I don't know. I've always just felt better with the access from above. So I would say well over 90% of my cases are above. A lot of it's just preference, but some of it's anatomical.
Okay.
I also prefer doing it from above.
Mm-hmm. Mm-hmm. Yeah, I just feel like you have a better view, but I have to be honest about it. I mean, these aren't usually defects in isolation. Many times, I would say that more often than not, they have a concurrent skull base defect. And so I'm repairing that concurrently, oftentimes. They've got, tegmen defect adjacent to that area. So yeah. And again, that's a whole other conversation about process. What is it? All BIH? Is it, just pressure and time? Is it, why are people having skull-based dehiscences? So I think sometimes there's multiple pathology there that you have to kind of address, and it's really hard to do that from below.
One last question about the patient. She had bilateral tinnitus. Was there dehiscence on the opposite side as well, or it was just transmitted?
Yeah. I think she has a good question, Aman. I think she has a contralateral, I believe. I can't remember.
This patient was that I presented was kind of a combination of two patients, just to get all the classic findings. So the patient that you saw, Dr. Basura, had didn't have like the classic air bone gap and low frequencies on audiogram. I don't remember off the top of my head if she had a dehiscence on both sides. The audiogram and CT that you saw today was for a patient with bilateral dehiscence, and then the audiogram and VEMPs were done after the right side had been repaired. So the left was unrepaired compared to repaired side. So a little bit confusing. I combined two patients here, but just to get kind of the classic features presented, since as we know, patients don't always read the textbook. But okay. Other questions for that one? Great. Okay, so we can move on to MS. This patient is made up, just to clarify before we go in. Again, just to kind of hit classic features. So we'll say this is a 37-year-old. She's presenting with bilateral pulsatile tinnitus. You guys have done great with our history questions, so we can kind of jump through that. We'll say this started several months ago. She's having headaches. She's having intermittent vision loss, photopsia, and eye pain. And then her BMI is 32. So what things are we thinking of here?
The differential would be idiopathic intracranial hypertension. But you'd want to do fundoscopy, check for papilloedema, do a full cranial nerve examination, and then you want to send her for a CT, right? Or MRV, just to assess whether it is in fact present and if it's safe to do a lumbar puncture, where you would then do opening pressures and typically would get an elevated level of opening pressures on lumbar puncture.
Great, exactly. And then what features of headaches are most classic for increased intracranial hypertension or increased intracranial pressure?
Like a constant dull, persistent headache that's central, but I'm not sure. Perhaps occipital. I'm not sure. Mina? I don't remember.
Are you getting a positional? Oh, sorry.
No
Oh,
problem.
yes, it's when bending down or something, I think I read.
Yeah, exactly. Worse in the morning, positional, things like that. Great. So we'll say we sent this patient for an audiogram, shows normal hearing. And then, like you said, if we refer to our colleagues in ophthalmology and neurology, I have out of order here, my MRI is next, so we'll go through that. But as you mentioned, looking for what do we find on this fundoscopic exam?
You can see papular edema with like the disc looks relatively, I don't know, enlarged. I haven't described it. I haven't described this in a while. But there's engorgement of the blood vessels and the disc looks almost like enlarged and edematous and irregular.
Perfect. Yeah, I would have just taken papillary edema. Great. And then on lumbar puncture, this image says greater than 15. I think most sources I saw said above 20, and we'll kind of go through the diagnostic criteria in a little bit more detail. Oh, did that not? Okay. This looks like my video isn't working, so we just have a still here. But what are some features we notice on this MRI?
Optic nerves are tortuous.
Yeah, tortuous superior ophthalmic vein. That's like perhaps edema. I don't know. And then you'd want to specifically look at your cavernous sinus and cellar,
You
to look for like an empty cellar.
look for the empty cellar sign.
Yeah, perfect. So some patients, particularly if their increased intracranial hypertension is chronic, will have empty cella sign. Unfortunately, this ended up being the video isn't working, so we just have the still. On that view, though, what we can see is that on both sides we have flattening of the sclera, protrusion of the optic nerve, which is consistent with that papilledema that we saw, which is this red arrow here. We can see that. And then the prominent subarachnoid space kind of next to the optic nerves, which are also tortuous, as you mentioned. So all features concerning for increased intracranial hypertension. So the diagnosis of IIH, there are two main diagnostic criteria. There's the modified Dandy criteria and the revised Friedman criteria. For modified Dandy, if you have an opening pressure greater than 25, symptoms like we talked about, headaches, nausea, vomiting, vision changes, papilledema. On the neuro exam, there shouldn't be any localized findings except for maybe unilateral or bilateral cranial nerve 6 palsies, which can be related directly to the increased intracranial hypertension. And then the CSF should be normal constituents, but just higher opening pressure. In order for it to be idiopathic, there can't be any deformity, displacement, or obstruction of the ventricles, no abnormalities on the neuroimaging except for empty cella, optic nerve kind of findings like we just pointed out, and smooth wall, non-flow related venous sinus stenosis or collapse, and ruling out kind of those other causes. If the opening pressure is less clear, if it's between 20 and 25, patients need to meet all of the requirements here, plus at least one of these other symptoms, which would be either pulse synchronous tinnitus, a cranial nerve 6 palsy, grade 2 papilledema, and an MRV with lateral sinus collapse or stenosis, or that partially empty cella. The revised Friedman criteria use kind of this range with, again, the kind of gray zone of opening pressure between 25 and 30. Patients have papilledema, normal neurological exam, again, with the exception of cranial nerve 6 palsy, normal imaging with the exception of findings we've already discussed, and then the opening pressure greater than 25. And then if patients don't have papilledema, they have to meet the prior criteria plus another one of either empty-sella, flattening of the posterior aspect of the globe, distension of the perioptic subarachnoid space, and transverse venous sinus stenosis. So clearly like a multidisciplinary diagnosis and analysis. I certainly don't want to be doing the lumbar puncture in my office, so we're getting our neurology colleagues involved, and optho for those exams. Oh gosh, why did this? Sorry, I don't know why I got locked out here. Give me 1 sec to get that pulled back up. Sorry, sometimes our internet times out. I don't know if it. So while I'm getting back to the slide here, what are our treatment options for idiopathic intracranial hypertension?
So this is usually managed under neurology. They'll give the diamox. They usually will encourage like a diet plan to get the BMI at least below 30. And then I think in severe cases, they can also do like a VP shunt or to try and divert the excessive CSF. So they do a VP shunt for the patient. But commonly, once we have the diagnosis, we refer this to neurology, and then the patients only come back to us if there is a new autological concern.
Yeah, perfect. So first line treatment is acetazolamide or Diamox to help decrease production of CSF, weight loss, which lowering BMI is like pretty impressive at decreasing the symptoms and the pressure. Can be challenging for patients, although with new medical weight loss management, perhaps more accessible. And then, as you mentioned, for refractory IH, neurosurgery colleagues can do either a VP shunt or a venous sinus stenting. So to summarize, pulsatile tinnitus warrants further evaluation and workup. Causes can be broadly categorized into vascular and non-vascular causes. Our history and physical exam, including our audiogram, are really key in guiding the remainder of the workup. Common imaging workup, at least at our institution, is a CT temporal bone, CTA head and neck, with additional workup kind of depending on that differential. And then management is variable based on the etiology. I have some like pop quiz questions at the end here, but does anybody have any questions before we move on to those?
No question for me.
That was really nice. Thank you. And you summarized everything really well. Would it be possible to share your slides with us?
Yeah, I'm happy to.
Okay, thank you.
Yeah, not a problem. I can get the best way to get them to you from Dr. Basura, if that works. And then
yeah.
Okay, perfect. And then if we have time, I have some pop quiz questions.
I love it.
All right. So we have a 48-year-old who's presenting to clinic complaining of unilateral tinnitus. Further questioning reveals that it's pulsatile in nature, present all the time. On physical exams, you see a reddish mass behind the tympanic membrane, which blanches with pneumatic otoscopy. What's the most appropriate next step in management?
E.
Exactly. So we're going to get a CT with contrast. What do we think this might be based off of the question stem?
Glomus tympanicum.
A glomus paraganglioma.
Perfect. And what is it called when the reddish mass blanches with pneumatic otoscopy?
Brown sign.
Brown sign.
Brown sign.
Exactly. I should give the disclaimer, I did not write these questions. I stole them from two question kind of sources. But yeah, exactly. So
you didn't put option D, perform middle faucet resection in clinic.
Exactly. Yeah. Yeah, that'll be, I'm just really trying to push the boundaries here at UPMC, life-changing medicine. We're at the forefront,
That's right.
All right. We have a 70-year-old man who presents with a 3-month history of right pulsatile tinnitus with hearing loss, unstable gait, and autophony. ECOG demonstrates an SP to AP ratio of 0.6. A diagnosis of superior semicircular canal dehiscence is suspected. Which of the following is a good indicator test that would give support to this diagnosis?
C.
Yeah, exactly. So again, going back to our VEMPs, I didn't include another summary here because we kind of went over those before. 2 more, I promise. And then a 49-year-old woman presents with sounds in her ears. A history of present illness reveals a beating sound in her right ear, which started suddenly about a year ago. She has not noticed any change in the intensity since it began. The findings of otologic and neurologic examinations are normal. Audiogram shows low frequency hearing loss. It was repeated with a light pressure over the right internal jugular vein, which resolved the hearing loss. What is the most appropriate diagnostic test?
C, A, and D. D. A or D.
So according to the question bank, it was D. I also thought it might be A, but the rationale they gave is that for pulsatile, CT is the CTA and CTV are the more appropriate diagnostic test. But
Because you're able to see the vein better. I think if you want to pick an MRI, it would have to be an MRV
MRV, yeah.
or MRA. So because you want to see the vessels, both the arteries and vein, especially given that you had changes with pressure on her internal jug, I think that's why D would be most appropriate. It would give you better vessel delineation compared to a brain MRI.
yeah, and I think that's exactly it because it's a brain MRI, not an MRA, MRV. So peak test taking kind of skills there in terms of not just like, I think I focused in on the MR and didn't think about the second part of like adding the angiography and venography. So exactly right. And then last question, we have a 65-year-old man who presents with a 3-year history of progressively worsening ringing in the ears. He says the sound is more pronounced in his right ear, but he can hear it in both ears. He says it seems to come and go with his heartbeat. Otoscopic exam is unremarkable. No masses are palpated. What's the next best step in management?
B.
Yeah, exactly, B. So I think the point here, again, from like a test taking standpoint is thinking about your progression of like how you approach a patient. So it's tempting to jump to imaging, but really like the next step is performing that really thorough physical exam. So auscultation of the neck. All right. That is everything I had for today.
You don't get a present for all the good answers.